There are currently 3 regimens approved by the FDA as a frontline treatment for patients with follicular lymphoma, advanced stage, and high tumor burden. 2 of them are represented by chemoimmunotherapy, and they're represented by BR, bendamustine and rituximab, or R-CHOP. And this is based on results of 2 very large randomized phase 3 pivotal trials, the STILL and the BRIGHT study. There's been also a very large randomized phase 3 trial called the Relevance trial, comparing chemoimmunotherapy to immunotherapy with a combination of lenalidomide and rituximab, also referred to as R-square. Unfortunately, the study was not positive because immunotherapy was not superior to chemoimmunotherapy as a frontline treatment. As such, it's not formally approved by the FDA as a frontline treatment, but because it was non-inferior, it's currently part of the NCCN guidelines. So in the United States, unfortunately, it's not the same outside of the US. You are currently able to prescribe in frontline either BR, R-CHOP, or R-square. However, we currently have no clinical or biological markers that we can utilize to select treatment options. So in this study, we were able to retrospectively analyze by bulk RNA sequencing with the convolution tissue biopsies that were collected before initiating frontline chemoimmunotherapy or immunotherapy in follicular lymphoma patients with advanced stage and high tumor burden. As a first step, we tried to understand if there was any biological difference across prognostic groups utilizing either FLIPI score, FLIPI2 score, or PRIMA-PI. What we saw was that patients who had high-risk disease by FLIPI score, they tended to have less B-cell receptor diversity and also a more regulatory T-cell type of signature. But beyond that, we didn't see any major biological difference, pointing to the fact that we cannot really utilize prognostic factors to select treatment options. As a next step, we compare signatures across the treatment types. And what we saw is that patients who had a normal B-cell associated gene signature, they seem to perform much better in terms of progression-free survival when compared with when treated with BR as compared to immunotherapy. Whereas those who had very high T-cell associated signatures, they tended to do better, again, in terms of longer, significantly longer progression-free survival when treated with immunotherapy. Of course, this is still a small study. Overall, less than 40 patients were enrolled, and we need larger data sets and validation, but this is very promising. What this is pointing at is that we can most likely utilize immune gene signatures to select treatment options in follicular lymphoma patients.